Chapter 29 is about assessment of the childbearing woman, and you probably will not have the opportunity to actually do this until you get into your OB nursing class, and they will be repeating a lot of this material at that time, but this will help get you ready for OB. Most of the physiologic changes, not only of the skin but of everything, many of those physiologic changes are driven by alterations in the levels of estrogen and progesterone. Progesterone is the hormone that helps maintain pregnancy, and it's going to be elevated during pregnancy. So one of the changes that you'll see in skin is the striae gravidarum, or stretch marks, and you'll see those on the abdomen, buttocks, thighs, and breasts, and some of them will go away, or they'll get less once the pregnancy is over, but many times they stay. They'll still be there. There will also be areas of hyperpigmentation. On the abdomen there's a linea nigra going down from the symphysis pubis. A black line is what the name means. In the face there's what phenomenon we call known as chloasma. It's also called the mask of pregnancy, and it's just a darkening of the face due to hyperpigmentation. And then can also be darkening of the areola and the nipples and the breast area, of the axillae, of the umbilicus, and of the perineum. So all those areas may be darkened. Then another problem is, or another condition that might occur, is spider nevi, and these are small vascular lesions that appear on the face, neck, chest, arms, and legs. And then you can get erythemas reddening too, you can get erythema of the palms, and another condition called pruritic urticarial papules and plaques, and this comes with itching as well as the skin, the papules and plaques that form. It's also called PUP, P-U-P-P, and this is usually seen in the third trimester. It will begin on the abdomen, but it can spread to other places as well. Then acne vulgaris, that just means common acne. It doesn't mean there's anything vulgar about it, it's just common. Common acne, and that can be seen on the face, back, neck, chest, anywhere you would see it in an adolescent. Hormonal changes, and those those result in increased activity of eccrine glands and decreased activity of apocrine glands. So you'll have increased formation of sebum and things like that. You'll also have increase in the basal metabolic rate. The BMR is that basal metabolic rate. You'll have an increased heart rate and more cardiac output. You'll have a greater blood volume too. Vasodilation in order to accommodate all that blood, and heat intolerance. Then you'll also have an increased growth of hair or nails, and after the pregnancy is over there will be a rebound where the growth decreases again. You may have oily, dry scalp. Hirsutism, that's caused by increase of androgens or male hormones, and that can be seen on the face, abdomen, and back. For ear, eye, nose, throat, and mouth, you'll have sometimes you'll have a decreased hearing and a sense of fullness in the ears, and that's just a result of that hyperemia. Everything swells up a little bit, and so you may have a little bit of conductive hearing loss there. Then it's frequent also to have some gingival bleeding, the bleeding in the gums, particularly after brushing teeth and things like that. Then epules are small nodules on the gums. Usually these will go away without any problem once the pregnancy is over. And you may even have a voice change, again from the hyperemia in the throat. And you may have a feeling of nasal stuffiness all the time. Epistaxis is nosebleeds that sometimes will occur spontaneously. As far as the chest and the heart, we'll have changes in the ligaments and joints are going to result in an increase both of the anterior, posterior, and transverse diameters of the chest. So this helps to accommodate the increased needs for oxygen, but it doesn't entirely compensate, so you'll have some shortness of breath. The diaphragm is pushed upwards by the expanding abdomen, and the breathing pattern is more ribs, more notably from the costal vertebrae. Shortness of breath, as I said, is fairly common. And you'll have increased tidal volumes. You also have increased cardiac output. The heart rate increases, and you may hear systolic murmurs, and those are usually normal, although you would want to have them checked out. The blood volume can actually increase as much as 40%. Changes in the breast, there may be tingling and tenderness. You may see enlargement of the breast and the nipple. Areas of hyperpigmentation, especially the areola and nipple. And then enlargement of Montgomery's tubercles. These are around the nipple area. They're sebaceous glands. And then prominence of the superficial veins. So you may see even some venous patterns. You may see veins on the breast that weren't apparent before. And the striae, the stretch marks. During the second and third trimesters, you may see colostrum. You can actually see that even in the first trimester, but it's much more common in the second and third trimesters. And then the person can have, the pregnant person can have a physiologic anemia, meaning that due to all this increase in volume, just as when you have a patient come in, a med-surg patient come in, and you give them some IV fluids, why their hemoglobin and hematocrit can drop. And basically the same thing can happen with a pregnant person as well, where due to this increase in blood volume, your hemoglobin and hematocrit go down a little bit so that it looks like they're anemic. The vessels are relaxed and they're dilated most of the time, and then this can lower the blood pressure, and you can have dizziness and lightheadedness as a result, and this is particularly common between weeks 32 and 34. And you may see some dependent edema. Well, with all the blood volume, everything is expanded, and then maybe the venous return is impaired by this full distended pelvic area that's putting pressure on the veins. So you'll see some maybe varicosities, you'll see the edema, and a woman in this condition particularly if she's on bed rest, is very susceptible to thrombophlebitis. Coagulation is enhanced as well to get ready for when that placenta separates, while you want your coagulation to definitely be working well. So that there's hypercoagulability. There may be venous stasis as a result of this pressure from the pelvis on the veins. And then if you add bed rest to that, well, you can imagine that makes it quite likely, or more likely, to have thrombophlebitis. Other abdominal changes, the abdominal muscles are stretched, and they may actually permanently separate, but normally they do go back once the pregnancy is over. The patient may complain of lower pelvic discomfort, and probably will. And then there is pressure put on bladder, kidney, ureters, and this is going to cause obstruction of the flow of urine as well. So you may have a functional hydronephrosis as a result, where fluid collects in that kidney and around the kidney, or it collects in the ureters, and all this urine that's not moving very well is going to cause a predisposition to UTIs. The same thing or a similar thing can happen with the small intestine, and there's maybe a decrease in gastric emptying time too. You'll have end result is heartburn, increased heartburn, constipation, and that decreased gastric emptying time can also result in nausea. And there's also an increase in formation of gallstones. And then there are two symptoms that can occur. Pyelism is excessive salivation that can also contribute to nausea. Pica is a craving for foods that are not nutritive, like dirt or other substances that are not nutritive. These become problems when they interfere with adequate nutrition. And the hormones, there's also changes in glucose metabolism, and during the first half of pregnancy, you're susceptible to hypoglycemia, and then during the second part, you're susceptible to gestational diabetes. And as you can imagine, if you were already diabetic to begin with, and let's say you had nice glucose control, but with insulin and everything, and you had your routine, well, the pregnancy is going to throw all of that off. So you're going to need to have reestablished glucose control. And they kind of, with the changes occurring throughout the pregnancy, so it makes it very difficult to attain that control again. Once the pregnancy is over, many times gestational diabetes goes away, and if you had diabetes to begin with, why, you might get back into control then at that point. Changes in the genitals, thickening. There's a thickening of the uterine wall, and there's also a major increase in vasculature to the uterus. And the top of the uterus is called the fundus, and we're going to be palpating that throughout the pregnancy, and even after delivery we palpate that to make sure that it is moving back to normal involution. We call that process involution after the pregnancy. But about 10 to 12 weeks, you're going to be able to feel that symphysis, that fundus at the symphysis pubis. area. About 16 weeks, it'll be halfway between the symphysis pubis and the umbilicus. About 20 weeks, it'll probably be at the level of the umbilicus. And then from then on, following McDonald's rule, we're going to measure the distance between the symphysis pubis and the fundus, and it should be about the number of weeks as the woman is pregnant. So at 30 weeks, it should be about 30 centimeters above the symphysis pubis. If it's markedly different, well, either maybe something's wrong with our calculations, maybe our calculation, or maybe something is wrong with the pregnancy. Lightning, that concept is that occurs when the head of the fetus engages in the opening, the opening of the uterus. It engages with the opening of the uterus. And so the fundus is going to go down a centimeter or two at that time. And it's called lightning because the woman feels a little bit of lightning, all this pressure she's been feeling. It's kind of a subjective symptom. And that's a sign that fetal engagement has occurred. Some of the other signs we'll see: the cervix gets softer, that's known as Goodell's sign. The cervix gets a bluish discoloration, that's called Chadwick's sign. There is also hypertrophy of the glands in the cervical canal, and there will be increased vaginal discharge, and this mucus goes to form a mucus plug, which helps to seal the pregnancy and prevent bacteria from coming up. And then the mucus plug is the first thing to pop out when the labor and delivery starts. Then there's changes also in the anus and rectum, primarily due to all the constipation, decreased motility. You may see hemorrhoids. Then as far as musculoskeletal changes, these are brought about by three things, really: by growth of the fetus, by the hormonal changes, and by the weight gain, as independent of the weight of the fetus. Why we have some maternal weight gain too. So you're going to see a lordosis occurring, and we also see increased flexibility of the symphysis pubis, and these virtual joints, these sacroiliac and sacrococcygeal, these virtual articulations, are going to become more stretchable and flexible, and that's going to help increase that fetal diameter. And some of the increase in pelvic diameter. Some of the increase in pelvic diameter is going to be permanent. And anyway, this is going to help the fetus to pass through by increasing that diameter. And mothers will also have a change in their gait. The gait is described as a waddling gait, like a duck waddles. They may also see a change in their shoe size, where their foot becomes a little wider, and they may end up needing new shoes. Neurological changes: you may have pain or tingling in the thighs. Thinking about that increase in pelvic size may put pressure on the nerve, the arteries. You have pain or tingling as a result. They may be carpal tunnel syndrome. You're thinking, well, that has nothing to do with the pelvic area. True, but just due to this generalized edema, there may be carpal tunnel syndrome. There may be leg cramps, and as we said earlier, dizziness and lightheadedness. So, history of the present concern. Many times, the pregnancy itself may be the first time that a woman has seen a doctor or healthcare provider in a long time. So the pregnancy itself, and they set up prenatal visits, and so it may just be a prenatal visit, but there could be a number of things that would cause a pregnant woman to come in. Stuffy nose. Some women will have a stuffy nose throughout the pregnancy, but that has to be assessed. And then if there's a persistent cough and frequent chest infections, that may be a sign of pneumonia. So just because something happens during a pregnancy doesn't mean that it's just because of the pregnancy. Sometimes there are treatable things going on as well. Persistent nausea and vomiting. Again, that many times that will be from the pregnancy, but it can be from other causes. There's a condition called hyperemesis gravidarum, which means gravidarum, that's just hyperemesis of pregnant women, and it interferes with nutrition, so that becomes a major concern. Maybe the concern for the visit is bloody stools, change in bowel habits, or maybe vaginal bleeding, leakage, or discharge. That could indicate that there's a problem going on. Loss of interest in eating as well, or trouble with sleep, depression, crying for no reason, or thoughts of suicide. There is a thing, there's a condition called postpartum psychosis, which, or postpartum depression can also occur. So there are very real psychiatric illnesses associated with pregnancy and the postpartum period as well. And you would want to be on top of those. And if you see any signs of depression, you'd want to make a referral to a mental health professional. Other problems might be breast pain or lumps, fluid leakage. All these things would be abnormal except for colostrum. Colostrum is a normal change of pregnancy. And then you might take this opportunity to ask the patient and do some teaching about what the plans are for nutrition of the baby. Whether she plans to breastfeed, bottle feed, maybe breastfeed for a little while. If you can't do the breastfeeding entirely, why, a little bit helps as well. You know, it's not like it's not necessarily an all or nothing thing. It's very easy to be judgmental with women that choose not to breastfeed, but as nurses, we should not be judgmental about these things. We just do patient teaching, but breastfeeding does not work for everyone. History. If the mother is going to be 35 years or older by the due date, why, we should offer her genetic counseling, because the risk of birth defects increases with age. And then when you're doing your charting, or when you're reading charts, you'll see grava and then the number X, para and the number X. So grava is how many times the person has become pregnant, regardless of the outcome, whether they were pregnant and they had a therapeutic abortion or an involuntary abortion, that's a miscarriage, whether they had a live birth, C-section, whatever the outcome, however many times they could have a grava of 6, meaning they were pregnant 6 times in their life. And then para is how many children they bore, how many abortions would be, and so that could be more than a grava. If they had multiple births, they could be para higher than their grava. Gravidity. Abortions, remember, an abortion is a delivery before 20 weeks, and that can be a therapeutic abortion, which is voluntary, or it can be what we call a miscarriage. That's also medically, that's called an abortion. So when you see has had 2 abortions, you don't go all, oh, what a wicked woman, she had all those abortions. Maybe we're talking miscarriages there, and certainly as non-judgmental nurses, we don't want to judge women's choices anyway. And then living children, noted that sometimes maybe you have a delivery, but the child dies in the first few days or the first year during the neonatal period or whatever. So living children is also listed there, number of living children. We would want to ask in our histories about previous pregnancies and how they went and what kind of delivery they had, if there were any complications with the pregnancy and delivery, and then complications with the neonate as well. Like that could be significant. And fetal losses. Whether it be, through miscarriage or through a baby who died shortly after birth or whatever it might be. One problem that we should be aware of is the situation of a mother who's Rh negative and then carrying an Rh positive fetus. And what happens in that one, the first pregnancy, usually nothing happens at all. The mother can become exposed to that Rh positive fetal blood. Usually when they do get exposed, it's during the birth process. So if they develop antibodies at that point, it's not going to affect that first baby at all. So during the birth, she becomes exposed to some fetal blood and she starts developing antibodies. If she becomes pregnant again with a subsequent Rh positive fetus, then those antibodies are going to attack the fetus's blood cells, and they'll be transmitted through the placenta, and so the fetus has a problem as a result, because the mother's antibodies are attacking her or his blood cells. And so to prevent this from happening, shortly after that first delivery, we give a vaccine called RhoGAM, and that prevents those antibodies from forming, and so subsequent pregnancies, there's no problem. Another problem that can develop are what is called ectopic pregnancies, and those are just pregnancies somewhere besides the uterus. The fallopian tube is a common site, or they can be freely out in the abdomen. And those pregnancies are not viable and have to be removed surgically when they're discovered. Did the woman previously have regular periods? That's important to know, because most of our methods for estimating the expected date of confinement or expected date that they're going to deliver. We estimate that based on the assumption that they have regular periods. So if their periods are not regular, those methods for estimating can be off. What birth control methods was she using? Particularly the IUDs. If there's an IUD that failed, then that does increase the risk of premature labor. And it's not a guaranteed thing. There are babies that get born all the time that go to term, and then the IUD comes out with it too. So that's not necessarily going to happen, but it's just something to be aware of if they were using an IUD and that IUD failed. If they were using the birth control pill, why then you'd want to stop those pills as soon as you found out they were pregnant. But depending on how quickly that occurred, they might get the pill for quite a while after the pregnancy's going on. Were there previous fertility problems, and were they getting some sort of treatment for it? Many of the treatments will promote multiple pregnancies. Like instead of you may have twins or triplets or whatever instead of just one. Then any previous reproductive surgery, any sexually transmitted infections either of the patient herself or of her partner, and vaginal infections, any history of a major medical problem, and any history of multiple gestation. History of allergies, history of previous hospitalizations for whatever reason, what medications is the person taking, and all of those have to be evaluated for what we call teratogenicity. Teratogens are medications that will cause abnormalities or problems in the fetus. So we want to evaluate all the medications for whether they're known teratogens, whether they many medications we're not sure. So typically what happens is we try to minimize the number of medications, and it sometimes becomes kind of particularly with things like seizure medications, it's like, well, seizures are bad for a pregnancy too, but is the risk of a seizure worse, or is the risk of this medication worse? And then, is the woman current on her immunizations? As far as family history, we'll want to know, has she previously had any child with a birth defect? Or did the patient herself have a birth defect? Because many birth defects are hereditary, and so we would want to know about these things. Is she a member of a high-risk group? And you can look in the textbook, various groups, ethnic groups will have be at high risk for various genetically transmitted conditions, and just about every group is at risk for something, but some groups will have specific risks that they run. Did anyone in the family have heart trouble before 50? That's frequently a hereditary thing. Anyone in the family with pulmonary disorders, diabetes, or cancer? Then turning to lifestyle and health practices. Of course, alcohol, tobacco, and street drugs. Did the woman do these things before pregnancy? Is she continuing to do them? Does she want some help to try and stop with some of them or cut down? We know that fetal alcohol syndrome can result in a number of problems, from microcephaly, irritable babies, mental retardation. Smoking is associated with low birth weights. And then street drugs, depending on the drug. Heroin is pretty notorious, where the baby itself will come out addicted and need to be weaned off narcotics. Typical daily diet, and a pregnant woman should get a balanced and nutritious diet. Do they necessarily? And if they do, they don't need supplements. But since so many women don't get a nutritious diet, why we want to get them on prenatal vitamins, and it's especially important to get an adequate supply of folic acid that is associated with neural tube defects. Pregnant women should avoid anything like unpasteurized milk or cheese, deli meats. These can result in toxoplasmosis, possibly, which is damaging to the fetus. They probably shouldn't eat like raw fish or things like that either. The book doesn't say that, but I'm going to go out on a limb and recommend no raw fish or raw sushi. Does she get adequate exercise? Are there any dangerous activities such as heavy lifting that that she does? Fatigue is a very common symptom during pregnancy. Any exposure to toxic chemicals, and exposure to cats, you would want to limit, particularly the pregnant person should not be emptying the cat litter box, and should be careful about petting cats. And the book even says if you are digging outside in your garden, if you are in a neighborhood where there's a lot of cats, why you should be cautious about digging outside in your garden. What is the occupation, and what is her typical day like as well? Then turning to some other more specific, like support questions. Is the father involved in this pregnancy, or how involved is he? And besides the father, what other social support does the patient have? If there are already children in the family, what are their reactions? I know I've been told that when my baby brother was born and I was 2, I was extremely resentful, and this is probably true. I plead guilty. And then you might want to ask, have you been threatened with physical violence, or have you been abused? Do you feel like you're being abused? This kind of thing that sometimes just directly asking will bring out things that the person has been hesitant to talk about, and it may open the floodgates and allow her to express these things. And then getting back to the partner, what is the partner's highest level of education? Does the partner use alcohol or substances? Does he smoke? And again, we're getting at trying to, we know that, for example, partners who smoke or use illicit substances are at a higher risk of being abusers. And then I don't know, education, people that are highly educated can be abusers too. Uh, Education is going to hopefully put you at a higher socioeconomic level, which will help a lot of things, but just because somebody's at a high level of education doesn't mean that he's going to be supportive or humanistic during the pregnancy at all. But then turning to objective data, of course, first we collect those anthropometric measurements. We collect the height and weight and vital signs. And we're going to be monitoring weight gain throughout the pregnancy. Inspect skin, hair, and nails. Inspect and palpate the neck, cervical lymph nodes, and thyroid, remembering all the different changes we talked about a little bit earlier. Inspect the eyes, and then the ophthalmoscopic exam, and you're going to be looking for vascular changes. Remember that you may see vascular changes, and the only place you can directly observe the vascular system is in the ophthalmoscopic exam. Then inspect the ears with an otoscopic exam. Again, remember we may have hyperemia there, or increased blood flow. Inspect the mouth, throat, and nose. Inspect, palpate, percuss, and auscultate chest and heart. These are using all the normal procedures as you would do for anybody else. Inspect and palpate breasts for symmetry and color. Inspect the face and the extremities, and then that's a good time to do your deep tendon reflexes. The abdomen, now we're going to do a few things a little differently. We would do our normal inspect, auscultate, and palpate the abdomen, but we're going to palpate for fetal movement, which you can expect after about 24 weeks, and uterine contractions and the height of the uterus, and you're going to also measure how high the uterus is over that symphysis pubis, and however many centimeters it is should be about the same number of weeks as the pregnancy. And then we get to the Leopold maneuvers. They're supposed to determine fetal lie, meaning the fetal's position in relation to the mother's back. Their presentation, are they vertex or breech presentation, meaning is the head or the buttocks or even feet the presenting part. Fetal size and their position. So to start the first maneuver, you put your hands over the fundus and you expect a soft irregular mass in the upper, either right or left quadrant. And that would indicate the fetus's buttocks. And then move your hand to the lateral sides of the abdomen, one hand on each side. You're expecting on one side some round nodules, which would be the fetus's fists, and on the other side a smooth surface, which would be the back. And then move your hands to the lower pelvic area just above the symphysis pubis, and then whatever you feel, grasp with your thumb and third finger, and this would be like a hard round surface, which would be the skull, or a soft surface, which would be the buttocks. And then with one hand on the fundus and one hand up on the symphysis pubis, you're going to try to move your hands together while pushing downward. And this is going to tell you whether the fetus, if you have resistance, that would mean the fetus is engaged. But if not, why then the fetus is still not engaged. Then next we're going to take either a Doppler or a fetoscope. A fetoscope is just a specialized stethoscope with a huge bell instead of a diaphragm. And we're going to try to find fetal heart tones. And if it's a vertex presentation, why they will be in the one of the lower quadrants, either right or left lower quadrant. You best hear it through the fetus's back, so whichever side the back was on based on your Leopold maneuvers, why it's going to be easiest to hear that on that quadrant, on that side, in the either the lower or upper quadrant based on whether it's a vertex or breech presentation. We also, besides where we want to note the location we heard it and chart that, but we also want to note the rate, and we should hear 120 or more. If it's less than 120, that's a sign of fetal distress. So we expect it to be 120 to 160 a minute. And that's something that when you actually get the woman into the labor room, why you may monitor, you may have a monitoring device on and be able to monitor the fetal heart tones without actually listening, and you'll see that on the monitor as well as you'd be monitoring contractions as well. I should mention here that that one piece that's missing from this chapter that we have not talked about at all yet is ultrasounds. And really and truly, the ultrasounds are going to be doing a lot of this assessment for us, where you still would do these assessment procedures, but particularly if your assessment procedure contradicts what the ultrasound is, well, maybe your technique was not right or something, but the ultrasound is your quick way of getting high quality information. Getting back to, we'll inspect the external genitalia, looking for any drainage, lesions, just as usual. So inspect the external genitalia. Palpate the Bartholin and Skene glands. They should be non-tender, not inflamed or anything. Inspect the vaginal opening for any cystocele or rectocele. And then take a scope, a colposcope, the word escapes me. We take the not the caliper. We inspect the internal genitalia, the internal vagina and cervix. Then you're going to also do pelvic exams, and this is particularly in the labor room. You'll be doing frequent digital pelvic exams where you take a lubricated finger and use that to estimate the length of the cervix, and once it's started to dilate, you measure the dilation with your fingers as well. Then while your fingers are in the vagina, you're going to also do a bimanual palpation, and you'll put one hand on the abdomen, and with the fingers in the vagina, then you push the two hands together to feel, to palpate that way bimanually. Palpate right and left adnexa. That's mainly looking for ectopic pregnancies. As I said, your ultrasound is your friend here. You would see that the ectopic pregnancy on ultrasound, and before it got to the point of having to palpate for it. But then someday you may be somewhere where you don't have an ultrasound. I don't know. Then you'd want to inspect the anus and estimate. Now the rest of these things are rather specialized measurements that are important, but they're things that either the obstetrician or the midwife will be doing. I don't think a nurse would be doing these, estimating the angle of the suprapubic arch, the height of the symphysis pubis, palpating the lateral walls, ischial spine, examining sacrum and coccyx, and measuring the diagonal conjugate. All of this has to do with measuring how wide and long the opening is in the pelvis, and basing that based on the size of the fetus's head, as you determine that by ultrasound, while you're trying to determine if this is going to be adequate, if the mother's pelvis is adequate for delivery or not. If not, then you need to make plans for a C-section, because it's much better to do a C-section knowing that you're going into that, as opposed to doing it on an emergency basis. So some of the diagnoses that you will get, you might get one: readiness for enhanced childbearing process, requests information about natural delivery methods. Remember, pregnancy is a time where you could be open to a person could be open to health promotion, and so it's certainly a time to promote better health. And many times the patients will be coming in for health promotion type visits because there isn't necessarily anything wrong, but they're just coming because they want to make sure that the pregnancy is progressing as it should. Risk diagnoses, we'll have lots of risk diagnoses. One might be risk for ineffective childbearing process related to continued use of alcohol, tobacco, drugs, whatever. But there are many other risks that we could have a risk for ineffective childbearing process related to uncontrolled high blood pressure as well. Then actual nursing diagnosis: interrupted family coping related to premature labor, as evidenced by family members sobbing in the room. Many times people have a dream of a perfect pregnancy, a perfect delivery, a perfect baby, and if there's anything that happens that blemishes that, why they go through grieving. They are expecting a perfect, even maybe the baby comes out okay, but they were expecting a perfect delivery and they end up having a C-section, and so there can be grieving as a result of that. Another diagnosis would be constipation related to changes of pregnancy, as evidenced by patient report. So that that concludes the section on the childbearing woman, the pregnant woman, and I'll see you at the next chapter.